Welcome, everybody, to the November Lifestyle Medicine Grand Rounds. I'm Dr. Ted Barnett, founder and president of Rochester Lifestyle Medicine Institute, and I'm so glad that you're all joining us tonight. And here's our agenda. Our case presentation will start in a few minutes with our presenter from Mexico, Dr. Fabiola, and then at 8:15 we're going to break down for Q&A with the audience. We will officially conclude this at 8:30, and we'll send you all a link so you can get your CME credit. And then at 8:30 we're going to officially dismiss everybody, but if you want to hang out and talk about things in the lobby, that's in quotes, we'll just hang out here for as long as people want, but probably about 15 minutes. Because oftentimes the conversation is getting interesting at just about the time we're breaking up. So we don't want to do that. We also have a number of free CME opportunities. This program, for one, is free, obviously. And we run Jumpstarting Health and Lift Project courses, both of which involve actual participation with actual patients and participants in a live Zoom program. And please check with our staff if you're interested in doing that. You can also partner with us. We run lifestyle medicine, ACLM certified programs for patients. And again, reach out to Brian Bell at rocklifemed.org for more information. Our guest panelist, Monica, is an adjunct clinical associate professor of medicine at the University of Florida, Division of Cardiovascular Medicine. She received her medical degree from Virginia Commonwealth University and completed her residency in internal medicine at Tufts New England Medical Center. Monica, we've had this conversation before, I think, because I was a medical student and resident at Tufts as well. She completed her cardiology fellowship at the University of Maryland. Dr. Aggarwal's medical focus pivoted after dealing with her own health challenge and the severe side effects of medications. It was only through learning about the microbiome, its impact on the immune system, and the role of nutrition in affecting the gut was she able to truly heal. Determined to change the face of medicine, Monica left private practice and returned to academics in order to pursue research on the role of diet and to create an integrative cardiology practice focused on nutrition and lifestyle. So welcome, Dr. Aggarwal. We'll have you turn on your video in just a second. It may be on, I can't see. And then Dr. Fabiola Flores Monsivais, I'm sure I didn't pronounce that properly. She likes to be called Fabiola, so we'll stick with that. She's calling in from Mexico today. She's board certified in internal medicine and lifestyle medicine, and is a full professor at the Health Sciences School at Universidad Autónoma, and has a practice in a public hospital. Along with her chef and surgeon husband, they started a culinary medicine and lifestyle medicine elective course to teach medical and nursing students how to cook plant-based foods and prescribe the 6 pillars of lifestyle medicine. Their teaching kitchen is the first in Mexico and Latin America. She's a member of the American College of Lifestyle Medicine and the Latin American Lifestyle Medicine Association, and a founding member of the Mexican College of Lifestyle Medicine, and has certifications by the Chef Coaching Program at Harvard and Plant-Based Nutrition by T. Colin Campbell Center of Nutrition Studies. I'm just going to go back a slide here. So Dr. Robert Breakey and Melissa Sundermann are regulars on our panel. Dr. Breakey is in Michigan and serves as the medical director for IHA's William J. Folletti Center for Lifestyle Medicine. And Melissa Sundermann had been practicing at IHA and is now at the Canyon Ranch in Lenox, Massachusetts. So welcome, Dr. Breakey and Sundermann. Let me go back here. Dr. Susan Friedman works with me here in Rochester. She is our presentation wrangler, case wrangler, and she's board certified in geriatrics and internal medicine. And I'm going to just skip over her, her biography and my biography so that we can get to the presentation, which is what we've all been waiting for.
I want to start by thanking the team of the Lifestyle Medicine Institute in Rochester, Dr. Ted Barnett, Dr. Susan Friedman, Dr. Bob Breakey, Dr. Melissa Sundermann, and of course, Dr. Monica Aggarwal, our guest panelist. Thank you very much for having us here.
Oh, you're quite welcome. We're excited.
I'm joining from Ensenada, Baja California, Mexico. I work at the Universidad Autónoma of Baja California. It's a public state university. And we're gonna start our case. Here is Rochester. Here is Ensenada. And our patient is from Veracruz. here.
Hmm.
I have written consent of Eunice to present her case and show her photographs, just to be clear on that. So she's a 24-year-old woman. She's a medical student, and she has jobs to help herself and her parents occasionally as a driver or waitressing. She was born in Veracruz, Mexico, but she lives in Ensenada. She's currently in Spain, in Catalonia, doing an internship. We're gonna start with her complaints. Her chief complaint was chronic tiredness, headaches, myalgias, lower back pain, abdominal pain, and acne. She had diarrhea alternated with constipation. And while she was in her menstrual period, she was irregular and she had excruciating pain. We all know, as students, the most stressful part of being a student is the exam period. So when she was going to have an evaluation, an exam, she was presenting with fever, cough, diarrhea, and body ache. When she was an adolescent, she was diagnosed with irritable bowel syndrome by a family physician, and she was prescribed antispasmodics and non-steroidal anti-inflammatory drugs. She was diagnosed with pre-diabetes in November 2019, and she was started on metformin, 500 milligrams once a day, and also was having headaches, and they diagnosed her with tension type headache treated with the same non-steroidal anti-inflammatory drugs. She has no past surgical history. Her family history, they all have type 2 diabetes, paternal grandparents, and maternal grandparents. And they also, her grandmother had a complicated type 2 diabetes with dialysis and foot amputation. Both of their grandparents have had cerebrovascular events, and her father and mother have type 2 diabetes. In her social history, she lives with her parents. She's lactose intolerant. She drinks coffee with milk, 2 cups a day. Alcohol, just 3 times a year on the holidays, red wine. She's fully vaccinated, non-smoker, no drugs. About her lifestyle, she's been an omnivore for 22 years with a low fiber intake, low water intake, 1 liter at the most. She consumes eggs 5 days a week, dairy 6 times a week, red meat 3, chicken 3 times a week, fish 1, vegetables 3 times a week, fruit 3 times a week, with high consumption of ultra processed food, low consumption of legumes, no consumptions of nuts and seeds, and no mindful eating, no hara hachibu. That's how her diet looked. She was sedentary most of the time, but during childhood and adolescence, up to she was 18, just right before going into med school, she was doing exercise, and she played as a member of the soccer, volleyball, and handball teams. She sleeps 6 hours per day. Sometimes she doesn't sleep before the exams. She ate more when she was nervous or anxious, and she didn't practice meditation or any other mindfulness activities. So these are her blog work on November 2019. And her BMI was 34, hemoglobin 13.5. This is when she was diagnosed with diabetes, 112. Her cholesterol is normal, triglycerides, they're normal. Her HDL is low. And she started having high ALT. Her ultrasensitive C-reactive protein, it's 5. Normal, it's less than 3. Waist, her circumference was 95 centimeters. So we're going to do our first poll. What are other diagnoses that you can find in this patient? 5% of the participants think she has metabolic syndrome. 46% think she has polycystic ovary syndrome, and 38% anxiety. I think they're all correct. In Hispanic, the Latin American Diabetes Association, in their criteria, they suggested that in order to have the diagnosis of metabolic syndrome, you must have 3 of various criteria. Among them, women, when they have more than 88 centimeters, their circumference, the abdominal circumference, when they have less than 50 in HDL for men, in this case, 40 for women. When you have hypertension or are taking medicine for hypertension, or your blood pressure is 130 over 85, and when your glucose, your blood glucose is above 100 milligrams per deciliter, or you already have the diagnosis or treatment for diabetes. So she had metabolic syndrome. Yes, that's correct. I'm going to give a space for Dr. Monica.
Just one of the things that just want to make sure, I know you said what you meant, but that the HDL under 50 for a woman and HDL under 40 for a man, just to flip that back around. I think you flipped it when you said it for metabolic. So just wanted to make sure clear, but I don't have a whole lot to offer here at this point, but to agree that this is sort of the classic case of patients we see all the time, right? That they have sort of early signs of metabolic syndrome. They'll be they have the central obesity, prediabetes, irregular menstrual, polycystic ovary, the sort of all the same pathology we're seeing in a lot of people, and the younger we're seeing them nowadays as well. And actually, this is every single patient I see these days.
Mm-hmm.
Yeah. Okay.
Yeah, let's continue with the presentation. We'll
hear
from the rest of the panel later. Okay, good.
So later on, she started having bronchial hyperresponsiveness. She doesn't have asthma, but she started having these attacks of she couldn't breathe and wheezing, and they prescribed her with loratadine and albuterol. Here she was in a class at the hospital, and they had to send her to the emergency room because she couldn't breathe. So that's when she thought, I need to do something. I have to change I can't keep going like this. So she went to her dietitian. She went with the nutritionist, and this is a diet they gave her. This is in Spanish. I just wanted you to see what they gave her. This is the translation in English, but it's a lot of words. So I think this is easier to see. You can see that there are a lot of colors. They have fruits and vegetables, but they have a lot of milk. And she has at least 2 glasses of milk every day. And this yogurt, they prescribe a yogurt to drink. Here in Mexico, they're very common. You can see here a sandwich with queso panela. This is a kind of cheese made here in Mexico. It's thought to have less salt, but that's just a thought. It's called also basket cheese. They allowed her to put some mayonnaise there. This is, you will see it in various, it's what you know as pico de gallo. This is salsa bandera. It's salsa with tomato, onion, cilantro. They gave her eggs, toast, more milk, cornflakes. She was allowed to eat cereal, cottage cheese, and more yogurt, granola. This is fish, or she could change it with soy ceviche. Quesadillas, do you know quesadillas? They're cheese among two tortillas. So more cheese, fried beans, and red meat, chicken. So this is a diet she was following through 2019 until 2021, because when the pandemic arrived, she was following this diet and she was going to the gym. She had to stop going to the gym because of COVID, but she would stick to the diet.
So Fabiola, just to clarify, that the picture you put up there, was that after she had her breathing attack and that's what they put her on? Or is
Yes.
that before? So she was sick, she couldn't breathe, she went to a nutritionist and that's what she was prescribed?
Yes.
And what year was that?
This is the end of
Yeah, that's
2019.
2019. Okay. And she was on that?
And she was in the emergency room in November.
Okay, got it.
The same year.
Got it. Okay, thanks. Yeah, let's put the poll up, please.
Okay. What would you change about her diet? How would you change what would you eliminate or substitute or add?
Yeah, let me just ask Dr. Fabiola a question. The last poll, we talked about polycystic ovary syndrome. I was just wondering, is how you I'm a radiologist, so how do you diagnose that without an ultrasound? But we'll go to this first. Okay.
Okay.
Yeah.
There are this criteria, the Rotterdam criteria, and that's the most recommended to diagnose. So you must have two of three criteria: the evidence of anovulation, the evidence of hyperandrogenism. It could be by a blood work, or it can be clinical. In clinical, it's hirsutism or acne.
Okay.
And the final is the ultrasound. Two or more, you diagnose PCOS.
Got it. Thank you. All right, let's hear about the poll. Looks like we got some pretty generalized agreement here.
Most of the people increase fruits, vegetables, decrease dairy. Thank you. Limit ultra processed foods. Yes. Some of them will increase granola and cereals. And this, I added this on purpose because if you say increase your cereals, you can misguide patients. You have to explain what a cereal is, what an ultra processed product is, and oat could be a cereal, but it's not an ultra processed food if it's a whole food plant-based oat. And some people said all of this. So if we're going, can I continue?
Sure.
Okay. So she's 20, 2020 and 21, and this is how she looked. She had this problem with her face in her skin. She was following the diet because they said she could eat tacos with red meat and corn tortillas and fried beans, and she is doing other activities. So after 2 years of following this diet, she lost 7 kilos, 15 pounds. And you can see that her blood work, the glucose improved a little. Her body mass index reduced because she lost weight, but there are no changes in cholesterol, triglycerides. At least they're higher. But her AST, ALT, they're the same. Maybe this one diminished a little. The GGTP it's more elevated, and the C-reactive protein is still high. So not a lot of changes.
So let's go back to that, please. And let's have,
Okay.
Dr. Aggarwal, could you talk about her lipid profile there, please? Are you there?
Sure.
Okay, great.
So when you look back, when you look at 2019, sort of comment on the whole lab panel and what I see here. So obviously she's overweight with a high BMI. She's pre-diabetic by blood sugar, if you're looking at that alone. Her lipids actually are really good, right? So she genetically is probably predisposed to very good lipids. So her total cholesterol is 96. I mean, most of my patients, boy, I rarely see a number like that in my clinic, at the beginning anyway. Triglycerides, despite her obesity, are actually quite low. Her LDL is 43, which is excellent. Remember, anything, when you're born, your LDL is between 40 and 50. So I often tell patients, especially my secondary prevention patients, that their goal is to get into that range where and people always worry about too low LDL, but to remember that your LDL when you're born and when you're growing and you're doing all of your brain growth, et cetera, you have an LDL of about 40 to 50 and you do just fine. Her HDL is 43, a little low for a woman. You always want it to be, especially a pre-menstrual or a menstruating female should really have an HDL above 50, but not horrible at 43, especially since her LDL is the same number. I almost wondered if these were accurate because they were so good. Her LFTs look good. It looks like she probably has a little bit of some of her LFTs are a little, I would guess, they are abnormal. Here's the normals. And, she probably has a fatty liver. High sensitivity CRP is elevated, which, goes along with sort of a high inflammatory state that she's in with her metabolic syndrome. In October of 21, I do see that I like seeing the improvement in her weights. Her sugars have improved slightly, but still in the pre-diabetes range. I wouldn't expect her cholesterol to improve much because it is really in a good place. But her fatty liver looks about the same. No real change in her inflammatory marker.
Right. Yeah, that struck me too, that she has an awfully low cholesterol. And Dr. Aggarwal, would you comment on if somebody has a total cholesterol of 96, is it really abnormal to have an HDL of 43?
That's
I know
exactly
we want.
exactly. It's only when your numbers are that low, we're kind of splitting hairs about numbers. So LDL and HDL being at that 1-to-1 ratio, even though I'm actually somebody who's not a huge fan of ratio. When people come in and say, but my ratio is, but in this situation, when the LDL and the totals are so low, this is incredible. I mean, these are the numbers, like I said, that these are optimal for heart disease, in terms of heart disease risk. But it just reminds us that that's not the whole picture. Remember in the Jupiter trial, which was a great trial that showed that people, even with optimal levels of cholesterol and had normal, quote unquote, normal LDLs, if their inflammatory markers were elevated, they were still at elevated risk for heart disease. And there was data to show that that's why even adding a statin on a person who has a normal, quote unquote, LDL, but has elevated CRP, if you added a statin and reduced that inflammatory marker, you actually improved outcomes. It just highlights the importance of that LDL cholesterol, and cholesterol itself is not the only thing we need to be looking at when we're thinking about patients in heart disease.
Right. Yeah, thank you for that. All right, Fabiola, why don't you continue, please?
Okay. So she wasn't improving, and she went to an internist, and they made an ultrasound, a liver ultrasound. Do you want to explain the ultrasound?
This is my chance to talk radiology. I've been waiting for a whole year for this chance. Thank you.
Thank you.
Yeah, so I mean, I don't think there's really necessarily objective measurements for fatty liver on ultrasound, other than to say this isn't the and you can't see my pointer here. So there's increased echogenicity to this liver. It's a lot whiter than it should be. It should be a bit darker than that. I don't know if they gave you a liver measurement, but we often will see enlargement of the liver. We often see something called focal fatty sparing. It's one of the ways we know there is fatty infiltration. You'll see a very echogenic liver with dark areas that oftentimes are right around the gallbladder. We don't really know why, where the liver is actually normal, but the rest of the liver, if you were to cut it open, would be very yellow, and the cells would be filled with fat. So yeah, so this looks like a pretty typical fatty liver, increased echogenicity, and it's really up to the technologist to make that diagnosis.
Okay, thank you.
Yeah.
So we have a patient with pre-diabetes in November of 2019, treated with metformin once a day, 500 milligrams, with irritable bowel disease, and this was with antispasmodic and NSAIDs, tension type headache, and now she was diagnosed with fatty liver disease, and she was started on, well, they increased metformin and they started as adenosylmethionine. Samir. And she started taking our course in February 2022. So this is at the end of November 2021, and she kept doing the diet and exercising in her house. She left the gym and she started our course. These are other students. Here is Jorge cooking. This is his camera, and this is her. These are her classmates, but this is her cooking. So we're going to do a cut in when she was 3 months in the course, and while she was taking the course, she told us that she had these problems. So we started doing this virtual, it's not a consultation, but like an interview to help her to do personally meals for her. And we told her to eliminate ultra-processed and animal ingredients, especially milk and all dairy products. She really liked this, so that was difficult. And high fructose syrup products, sodas, the sweet beverages, bread, it all has high fructose syrup. We told her to substitute a few things. She, instead of using salt, use salicornia. Salicornia is a plant that grows on the side of the sea, and they dehydrate it. You can eat it fresh, but they dehydrate it and they make this sal verde, green salt. Salicornia is an allophyte plant, and also suggested to stop using sugar and use more use dates to add sugar or sweetness to her food. And we showed her how to make her own date syrup homemade. We suggested almond, soy, or oats beverage instead of milk. She really liked milk and in her coffee, so that's what we suggested. And for the cheese, we suggested nutritional yeast. These are a few recipes we gave her. This is mayonnaise, but it's made with tofu. It doesn't have eggs or oil. And we taught her how to do her own milk with almonds or oats, and to incorporate new ingredients, to taste new ingredients. And that was one of the focus of the classes, to taste new spices, vegetables, fruits, nuts, seeds. In the class, they can choose one ingredient, so Jorge can create a dish for them. Sometimes they ask for dessert, that's the most common. Sometimes they ask for pizza or pozole. And so one of our students wanted a recipe with eggplants. They haven't tasted eggplant. So he created these roasted eggplants in white bean puree and tamarind sauce. And this is in the nutrition studies website with Dr. Campbell. If you want, I can share you the link. And what we taught her in the course is the 6 pillars of lifestyle medicine. We taught her the difference between having a whole food plant-based diet and being vegan. They most of the time think it's the same. We made clear that it wasn't. This is something that it's been really helpful to teach them the NOVA criteria, the classification system of Dr. Monteiro, to learn to detect the products they're buying at the stores, and these colors, green with the ones you can buy and red with the ones you can't, that's really, really helpful for them. So you can see in the group 1, there's animal ingredients. So we specified that she shouldn't focus on dough, no animal ingredients, and no group 3 or 4. And to give an example, a group 1 ingredient is chickpeas. A group 2 is the flour made by chickpeas. You just ground them and you have the flour. Group 3 is like a pastry with the chickpea flour. But the group 4 is the same pastry with whipped cream and covered with chocolate and sprinkles and all that. We taught them to read labels, and we use a lot of the teachings of Dr. Jeff Novick's presentation. And the most important is the cooking classes. They buy their own ingredients. They learn to pick them. They cook the dishes, and the most important, they smell it and they taste it. So after 3 months of being in this course, she was 78 kilograms. She lost 10 kilos. This is her glucose, 87. Her cholesterol dropped a little bit more. This is her triglycerides, LDL, HDL. It went lower, but she wasn't exercising. So we told her that she needed to start exercising. She lowered her AST and ALT, and it's almost normal, but it's still high, the C-reactive protein. So what would you do now with her medication? Remember, she's taking S-adenosyl methionine, and she's taking metformin. Would you increase metformin? Would you maintain or suspend adenosyl methionine? Would you suspend all her medication? You can choose more than one.
So
she's really compliant with the treatment.
Fabiola, can you put back up her numbers for us, please? I want to ask Dr.
Yes.
Aggarwal to comment on the numbers again.
You know, numbers obviously in April look excellent. So, right, her weight is down. Her body mass index is still in the overweight category, but significantly improved. Remember, BMI over 25. Her sugars are down, so she's no longer in the diabetes range. Her cholesterol continues to look very good. Again, I wouldn't focus so much on her HDL and not that it's not above 50, because her numbers in general are extremely low, and these are great numbers. So obviously exercise is good for many reasons, but not worrying about her HDL per se is not indicated in the situation. Her LFTs have resolved and normalized, so she's out of that fatty liver. I agree that her HSCRP is still a little bit elevated. I'd like to see that come down, but I think more of the same. And as her weight continues to come down and her lifestyle changes persist, this will also improve.
Great, thanks. Have we seen our poll results yet? There we are. Okay.
Yeah, great. Almost everybody will suspend the medication. So that's what we did. And she kept taking the course. This is the course 6 months later. We kept with the activities. They participated in Meatless Monday campaign, teaching patients, cooking in person and with community activities. These are some of the recipes that she introduced to her diet. These are date and cacao spheres. These are great desserts to help with the need or of sweet flavors. This is barley with pineapple. This is pozole, but it's pozole, vegan pozole, plant-based pozole with portobello instead of meat. These are chocolate tamales with berries. This is barley with chocolate, and this is a nopales salad. So, well, we already said all of this. She lost 20 more pounds. She wasn't tired anymore. No abdominal pain, no back pain. She had less acne. Her headaches disappeared. Her menstrual cycle got regular with less pain. She started on vitamin B. She was started on vitamin B12 because she kept with the diet. Now she's been 6 months on whole food plant-based diet. She started meditating with 3 to 5 minutes a day with an app I recommend, Insight Timer, and she's sleeping more. So this is her last lab result 2 months ago. She kept her weight, but she improved a lot her numbers. I don't know if Monica wants to comment on this.
Yeah, it would be great. Dr. Aggarwal, sure. And
Yes.
She started exercising 10 minutes daily.
Yeah, I think the numbers look fabulous. So her LDL's 8. Is that accurate?
Yes, I thought it was a mistake, but it was in two labs, in 2 reports.
And she's not on any statin medication. This is odd.
No.
These numbers are a bit odd, I have to say. So her lipids do trouble me a little bit with the LDL of 8 without any medication. So, you know, she probably benefit from a little bit of genetic testing, but let's get through the other numbers. So obviously her weight unchanged, BMI still unchanged, glucose is very nice, impressive, total cholesterol looks good, triglycerides great. The only thing that, you know, bothers me a little bit is that LDL being low. And other than that, her LFTs look great. HSCRP looks good. Now, I don't think that she's certainly I'm not suggesting that her LDL concerns me in terms of her heart disease risk, but I would want to be sure that I understood that her liver was functioning well. Because I've actually never seen an LDL that low off of medication without even with an aggressive dietary change. So that number is a little bit troublesome to me. So I don't know if you did any workup in terms of her to make sure that her liver synthetic function was okay and those kind of things.
Although look what happened. Look what happened to her HDL went way up. Look at that. Because that's from the exercise, we think, right?
Oh yes,
Yeah.
I do see that now. Her HDL is up. Very good.
Yes. We couldn't do the other ultrasound and more labs because she's in Spain right now. But maybe when she returns. This is her right now in Spain. And this is what she said. My face after spending all day walking around Madrid and going to a concert, and I have no makeup base. So you remember her acne, and well, I think the biggest change is her smile.
Mm-hmm. Lovely. Yeah.
Thank you for the opportunity to present. And these are our websites and our social media.
Excellent. Excellent. Well, we'll share that with everybody. So let's, why don't you stop sharing? Let's hear from Dr. Sundermann. We haven't heard from her. I know she always has a lot to say. And thank you, Dr. Aggarwal. That was terrific. And Fabiola, thank you. That was a great presentation.
Thank you.
Thank you, Dr. Fabiola and Dr. Aggarwal, for all of your insights in the case. So I just have to say, what a gift you gave to this young woman, not only to her personally, but also to her as a physician, right? So you educated her to empower herself, and now is going to set forth with this knowledge, which is what we're trying to do and shift the paradigm. So thank you for this journey that you're doing with so many medical students. And I think that when you started back with her family history, right? I mean, she's a perfect example of genes are not your destiny. And that everyone in her family had heart disease and debilitating diabetes to the point of amputations, and very easily could say, well, this is in my gene pool and this is what I'm bound to have, and I have no control over that. So just prove that myth right then and there. And then also, quite obvious, I think, to all of us in the room was, I'm sure the physician who was seeing her was a very capable physician, but not a lifestyle medicine physician. And so a lot of Band-Aids put on symptoms without getting to a root cause. You have a headache, take, an NSAID. You have an elevated glucose, take metformin. Your liver looks a little fatty, takes, SAMI. So a lot of Band-Aids put on without getting into root cause. And then the nutritionist obviously comes from a different scope. And I was like, on the first slide, she's lactose intolerant. So why are we keep feeding her all of this dairy? So I think, had probably really capable, educated treatment team, but just very different knowledge base or approach than lifestyle medicine. And if it wasn't without your intervention that she took this course, I think she probably would have been on more medications and just chasing numbers, and didn't want to get the proper education as far as food as medicine and movement as medicine, and really to how to approach it. So I'm just so grateful what you've given this young woman and what she'll set forth in bringing lifestyle medicine into her career. So thank you.
Yeah, thank you for that, Dr. Sundermann.
Thank
Dr.
you,
Breakey.
Melissa.
Yeah, Dr. Breakey, what are your comments?
Well, at the beginning, she was really out of balance. We kind of compare with average Americans, say, well, she's obese, but that's like a third of others. Her glucose is only 112. This fatty liver, this insulin resistance, this obesity is affecting every cell in her body, every hormone. And this is a great example of how, kind of comparing to, well, she's not that bad American. If she walked into a blue zone like that, they would say, oh my gosh, put her in the ICU. This woman is in severe metabolic imbalance. Her pancreas is trying to kick out insulin. Meanwhile, it's getting fatty infiltration, so it can't. It's getting on the verge of burning out. You didn't talk much about her blood pressure, but clearly, as Melissa mentioned, a root cause assessment would tell us several things that, we all know the pillars, but we're learning much more about the mechanisms now. And what we know is that this woman has severe microbiome dysbiosis. She has irritable bowel syndrome as an obvious manifestation of that, but the pro-inflammatory nature of the gap junctions and her colonic inflammation, the fact that the healthy and diverse microbiome are not detoxifying things or producing nutrients for her, leaves her whole system out of kilter. In addition, we now know that dairy products are nature's growth message. To get a 65-pound cow to a 600-pound bull, you need not only fat, salt, and sugar, which is what it's got, but you need IGF-1 hormone, and you need to stimulate mTOR gene expression that creates growth and obesity and fatty liver. And so again, being in practice for 43 years now, I've seen this movie before. This 24-year-old woman who was looking like, okay, pretty average American so far, was in severe metabolic imbalance. And fast forward 10 years with diabetes and a toe amputation, and then even though her cholesterol's low, vascular disease and inflammation throughout her system that leads to arthritis, and then compounds downhill when her knees give out and she can't exercise, and she gets stress eating and depression, serotonin imbalance. All these things, I agree with Melissa, not only saved her from a life of suffering and misery, but have taught her firsthand in a way that will allow her to affect the lives of literally thousands of patients over the next several years. So thank you. You have made a great advance in helping her to turn this around in a way that will leave her with a knowledge base that not just clear her skin so she's happy she doesn't have to wear makeup walking around town, but with a knowledge base that helps her now to spread a message of hope, of vitality, of empowerment, in spite of what the well-intended nutritionist was trying to teach her. So thank you.
Yeah. Thank you, Dr. Breakey. Dr. Aggarwal.
Thank you.
Yeah. Dr. Aggarwal, any general comments on this case?
So, I thought it was a good case. I liked it. I think everybody's comments were appropriate. I think it highlights, I love the comment, that Susan made about, root cause and how, we sort of miss the boat so much of the time as physicians. I really like the culinary intervention that you did. And so, one of the things I always tell people, it's not about giving people healthy food. It's about showing them how to cook it and make it and why they need to eat it. And so I think that's what you did brilliantly in this intervention. And now that she's a medical student and you're working with students, the beauty is that she will now teach her patients. And that's the real gift that you've given her, is that when you teach a doctor, you teach all of the patients as well. And so I really like that. I think that the culinary intervention, I really just want to highlight that again, because so much of the time we tell people that you need to eat this food or that food, but people don't like that food or this food. And it's really important to kind of remind them why they're important, but then also give them ideas on how to cook them and how to make the foods. And so one of the things that I do in my clinic is I give everybody a grocery list. And so I recommend, if they're busy clinicians out there, and nobody should be judged. Everybody's doing as good a job as they can out there. It's a hard life as a physician, but little tricks that you can do, or you can do things like the Starting the Conversation survey, which is a really great survey to give to your patients if you're running a busy clinic, because it really just highlights how to start the conversation about diet. So I really recommend that. You can pick that up off the internet really fast. The other thing is it's well known now that, most physicians spend less than 3 minutes of their time counseling patients on nutrition. And sort of, if you use that Starting the Conversation survey, it just does get people motivated, and remembering and reminding physicians that patients really listen to their doctors, and they don't change and make changes necessarily after the first visit, but they do listen, and that over time they will change. I like the idea of the grocery list in particular is a really quick thing you can do ahead of time, and pre-make grocery lists for people, and sort of also highlight some of the pertinence, like these are the 3 or 4 breakfast options, these are the 4 lunch options, because I think that the average clinician gets very frustrated with this lifestyle medicine conversation, in the sense like, yeah, we know that people need to do these things, but we just don't have the time to impact change. And so I just want to remind people that sometimes these little hacks and little tricks can make a huge amount of difference. Grocery lists, like I said, sort of setting up some basic breakfast, lunch, and dinner activities or recommendations for people will really help them. And then sort of also learning to meet people where they are. I like to remind people that, and as physicians, and sort of sometimes as plant-based advocates that we are, and as I am, we have to remind people that not everybody knows what a quinoa is, or knows what a nut butter is, or knows how to use tofu, and to remind people remind us as physicians that our goal is not to judge, and we're trying to meet people where they are and try to bring them slowly over to where we can modify things. Okay, well, if you don't know what tofu is, well, what about, would you eat beans? And what, I don't like texture of beans, and to remind people that, okay, well, if you don't like beans, these are ways you can like beans better, and maybe if you puree them. And so just sort of highlight some of those culinary interventions, because that's the most important thing, is that she's taught her how to make the changes. So bravo there.
Thanks for that, Dr. Aggarwal, especially some of those hacks. Okay, one other little hack, I'll make a shameless plug here, is to refer your patients to our 15-day whole food plant-based jumpstart. where we spend a total of 11 hours over 7 visits on Zoom. So people can learn all about those things and learn what Fabiola has done such a good job teaching her student. So it is 8:29, and I know I promised we were going to have audience Q&A. What we're going to do is we're going to actually move into the lobby at exactly 8:30, and we will continue to have participation. I would love to hear from participants in the audience and more from our panelists if they can stick around. But please check your email. You will receive an email from us that will give you a link to a survey, and once you fill out the survey, you will receive 1 hour of CME for free for attending this conference, this grand rounds, and but if you want to stick around, we'd be happy to have you. So anyway, I'd like to thank our panelists, Dr. Monica Aggarwal, Dr. Melissa Sundermann, Dr. Robert Breakey. Thank you so much for your insights. And Fabiola, I want to call you by your last name, but it's not written on your screen. So it's Dr. Flores, right?
Flores Monsivais.
Yeah. Okay. All right. So thank you so much for that presentation. It was a wonderful presentation. I know you put a lot of work into that, and especially thank you for doing such a wonderful job with your patient/student. I mean, as Dr. Sundermann said, she is going to go out and change the world with what you've taught her. You know, she's learned the lesson. It's one of the things that we talk about in our cycle of culture change. You know, once you find a doctor who's sick and then they get better by doing lifestyle medicine changes, then now they're persuaded. They're much more likely to try to persuade their patients. Very good.
I
very
just
good.
wanted
And
to say
by the way-
that I
Go
presented
ahead.
the case, but this is the effort of a lot of people in my university. And
Mhm.
Jorge is the main, he's the chef and surgeon leading the students and teaching them how to cook.
And he's your
So
he's your
this is
husband-
not
he's your husband,
my
right?
credit. It's a whole team in our university.
Does anybody have any questions or comments in the audience?
No, I think it's great. I mean, I think this is obviously the missing piece is people, I think, want to change, but they don't know how. And without the cooking part, they're just not likely to get it because
Mhm.
all they're going to be buying is crappy food. So
Right. Right. No, thank you for that. Okay, if people can, I want to turn their videos on. We're happy to see faces now. There we go.
Ted, if I could comment,
Sure.
there was a question in the chat from Dr. Deb from Michigan about low cholesterol being correlated with possibility of cancer.
Right.
But where that comes from is that certain cancers, in particular breast cancer, kind of feed on cholesterol. In the early stages, it doesn't matter, but in the late stages of breast cancer, you can see a sudden drop in cholesterol as it's all kind of sucked into the cancer cells. Therefore, if you look at a broad number of people with low cholesterols, a certain number of them, it's because of cancer. It doesn't sound like it's that case in her case. Something would have shown up if she were in late stage cancer over all these years. But it's sort of like when you look at underweight people, you say, oh, they have a higher mortality. Well, that's because some of them have cancer and rheumatoid arthritis and wasting diseases. But if you look at healthy ones, a BMI of 18 is fine.
Right.
Same thing here. If you look at healthy people with a low cholesterol, that's a good sign.
Right.
But it's an interesting observation that from Dr. Deb, and I don't know if she has any comments or thoughts on what she was thinking when she asked that question, or anything to add to that. Deb?
Dr. Debbie.
I was just mentioning that it's not necessarily cause and effect, but they've done studies where they've seen people with very low cholesterol who had cancer, but doesn't mean if you have low cholesterol, you will have cancer.
Right. Yeah, I think that's an important. I think that's a really important point, because there's that rumor out there that having a low cholesterol is bad for you because, right, the high mortality rate, which was Dr. Breakey was talking about, and you really need to know the argument against that, which Dr. Breakey gave you very, very well, which is that there are people who have chronic illness who are really sick. For example, have cirrhosis. They've been drinking themselves to death, and they have a low cholesterol. Well, it's because of it's not cause and effect. It's the other way around. So it's important to know, because sometimes people will throw that. You say, oh, having a low cholesterol is dangerous.
Mm-hmm.
So.
No, and what Dr. Monica said, it's important. Genetics, it affects, because there's the Tarahumara Indians, they're Mexican too, and they have really, really low LDL and total cholesterol. Well, before the ultra processed food arrived, but they
Mhm.
used to have.
Right, right.
Mhm.
I'm curious from our expert panel about what do you think her odds of having heart disease are? I mean, she's quote heart attack proof, right? If you use Dr. Esselstyn's term, if she hadn't gone on this program, right, and she still had a high HSCRP, would you think the risk of having a high HSCRP is greater than having the benefits for having a really low LDL? Do we even know?
I feel like she was a ticking time bomb that just, it was only going to be a matter of time where she was going to develop full-blown type 2 diabetes. And, I'm sure her blood pressure would continually to rise. And I just feel like, yeah, she was going down that pathway. But Dr. Aggarwal would be the expert in that as far as cardiovascular risk. But with that high of CRP and that amount of inflammation, I think that she was setting herself up for that.
Right, I agree.
You might also want to look at some other factors, her ApoA, her homocysteine, her other inflammatory markers, because as you suggest, it's cholesterol is a huge component. And I think when we talk about less than 150 and less than 70 for cholesterol and LDL respectively as heart attack proof, we have to caveat that with that's in a kind of a normal population. Clearly, she's got some kind of genetic reason for low cholesterol, and maybe for that cause, it isn't for her. So it's a good question, Ted. I wondered that myself. And I don't know if Dr. Aggarwal is still on, or we can
I think
ask
her-
that of expert like Dr. Esselstyn or Dr. Williams and see what they think.
I think
Well,
the
one question I would
hurricanes
have
are
if
her-
Dr. Aggarwal is still on. I'm now at Canyon Ranch and we do a little bit broader blood panels, and we do NMR analysis of cholesterol, which gives you LDL particle size. And you can really, I think, what they say is predict more. So I just don't know if there's any other cardiologists on board or lipidologists who have been using NMR and whether they feel like that brings more information, because you could have an LDL that looks okay, but the particle size sets you up to be more prone to cardiovascular atherosclerotic disease.
Right. Do we have? I know we lost Dr. Aggarwal.
Okay.
I think the hurricane got her. If there's any cardiologists in the group or anybody who wants to address that question about particle size, I guess not. I think. I think the fact that we're seeing her HSCRP or high sensitivity CRP go down, and she did mention the Jupiter trial, which is where how I know about that. That's a significant risk factor, and that we're seeing that go in the right direction. So that's a really good thing.
I think it was great that you had lab work going along so that she could also see the improvements that were being made, because I think that's such valuable information for our patients to have that objective data to say, oh my gosh, I changed, I exercised a little bit more, I changed my diet a little bit more, and it's actually making an impact. So there's, subjective where she's feeling better, maybe her skin's a little bit better, maybe her IBS is improved, but then when they see that objective data, I think that can be really empowering.
Yeah, I agree.
There's another thing
Yes.
sometimes you see is patients who say, oh, doc, but my cholesterol's fine, everything's fine. And you have to be a little careful about that sort of one number thinking. She's obese, she's got insulin resistance, fatty liver, and acne, mTOR stimulation. She's hyper inflamed, but my cholesterol's fine. So people think I don't need to make any changes. They sort of key in on the one thing that's good, and then think that all your talk about these other things doesn't matter. So we have to be careful about that, and we see that sometimes in any number of things. Hey, I'm normal weight, so everything's got to be fine. Even though my cholesterol is 280, I can't have a heart attack because I'm not overweight, or my blood pressure is fine, or whatever. So it's the whole gestalt picture that we have to help people to look at, just like it's the whole food, it's the whole health picture that helps us to make a plan for people that will help them to function at their best, really, at a cellular, organ, and whole organism level.
right? And
Mhm.
she may have had really good cholesterol from the get-go, but she didn't feel well, right? I mean,
Right.
bottom line, she
Yeah,
didn't feel well.
hello.
Yeah, exactly. Yeah. Looks like Dr. Deb has her hand up.
Oh,
Dr. Deb, did
yeah,
you-
I just was gonna ask a couple of questions. Did we have a blood pressure or any blood pressures throughout on this patient, this particular
Yeah.
case?
Good question. I wondered about that too.
I didn't see
No.
that, or thyroid, also thyroid, possibly. You know, she was on a lot of NSAIDs. I kept seeing that pop up as recommendations for things, and that can really mess up. She already is having gut problems. And there was, how many, do we know how much NSAID she was actually taking on a daily basis to start?
Fabiola?
She was taking naproxen, is it the same
Mhm.
in English?
100%, yeah.
Naproxen. And we had to stop the acetaminophen because she was taking a lot of it, even with the fatty liver disease.
Right.
I think ketorolac too.
All right. Well, listen, it is now almost 15 minutes after the into the lobby here. So we're gonna I think we're gonna say goodnight. So we have a tradition here where we like to at least unmute. You don't have to turn off your video or turn on your video, but we love to hear voices from all over the world. So I'm gonna count to 3, and if people unmute themselves, we're all gonna say goodnight. 1, 2, 3. Good night.
No,
Good night.
thank
Thanks,
you.
Deb.
Thank you.
Thank
Thanks.
you.
See you next
Gracias.
month.
See you next month.
you.
All right. All right, thanks,
Bye.
everybody. Bye-bye.
Gracias.
Happy Thanksgiving.
See you at ACLM.
Yeah, see you
Yay.
next time.
Great.
Yes.
Absolutely. Yay.